Hi, everyone. Welcome back. I hope that you've been enjoying the mini course so far. We have multiple mini videos for you on special topics. The special topic that I will be talking about in this short mini video is buprenorphine best practices in special populations. In this short mini video, we will be talking about buprenorphine management in pregnant persons, adolescents, and individuals with concomitant pain. A lot of what we'll be reviewing today is based on the National Practice Guideline that ASAM put out and updated in 2020. Please go back and review the National Practice Guideline if you have questions or you would like more information. Starting with best practices for pregnant people with opioid use disorder. Based on the National Practice Guideline guidance, treatment with buprenorphine should be initiated as early as possible during pregnancy. Patients should be advised to continue these treatments during and after pregnancy because these treatments are so effective. Buprenorphine should not be withheld if patients decline psychosocial treatments. We also know that there are many physiologic changes that occur during pregnancy, and these can alter buprenorphine metabolism and generally necessitate an adjustment of the buprenorphine dose and dosing interval. So for this reason, as pregnancy progresses, generally, we are needing to increase buprenorphine doses to greater than or equal to 16 milligrams per day. And many pregnant people find that more frequent dosing, such as 2 to 4 times daily, may be needed to achieve more consistent, effective buprenorphine plasma levels, and certainly prevent opioid withdrawal between doses. So please think about increasing the dose as pregnancy progresses and increasing the frequency of dosing if patients are experiencing increased craving or opioid withdrawal during treatment. Importantly, as patients get ready for labor and delivery, it's important that we recognize that withholding buprenorphine treatment can actually be detrimental to them. So we want to continue buprenorphine treatment at labor and during delivery, even if the person is having cesarean section. And there's certainly literature to support ongoing use of buprenorphine even during episodes of acute pain. There's emerging evidence about extended release buprenorphine as a safe option for pregnant patients. We need more information and literature to support its use, but this is an emerging strategy if you have patients who are having difficulty stabilizing during their pregnancies. And then finally, breastfeeding is encouraged while folks are being prescribed and taking medication treatment, both buprenorphine and methadone. And a framework such as the Eat, Sleep, Console framework, once the person has delivered, can be an effective strategy to reduce symptoms of opioid withdrawal for the neonate. So we recommend this type of a framework and sleeping in with the baby after delivery to reduce any symptoms of neonatal opioid withdrawal. Moving on to adolescents. So this is an important group of people who generally have had less access to medication treatment. So it's important for us to recognize that this is a group of people who are high risk of opioid overdose and complication if they do not receive treatment. And in fact, youth are only 1/10 as likely as adults to receive medication treatment for opioid use disorder. This can be related to youth not having access to clinicians who can prescribe to them. Clinicians may be having discomfort about prescribing to younger people, stigma related to medication treatment for opioid use disorder, and individuals thinking that medication treatment should not be offered to adolescents. However, we know that over the last 2 decades, opioid-related overdose mortality among adolescents and young adults has increased dramatically. So it's important that we are offering medication treatment to adolescents and young adults who have opioid use disorder. And we want to do what we can to reduce barriers to receipt of medication treatment. Similar to pregnant people, we don't want to withhold medication treatment from adolescents who do not want to engage in psychosocial treatments. And hopefully, as they get more stable in treatment, we hope that they may want to start to engage in those treatments. Adolescents may benefit from treatment and specialized treatment programs that provide multidimensional services. And if adolescents are interested, offering these services is important. Finally, we want to do what we can to reduce stigma and increase education among families, treatment programs, and clinicians so that adolescents and young adults are able to access these life-saving treatments. Finally, we're going to discuss individuals with opioid use disorder and pain. Chronic pain is a common problem for individuals who have opioid use disorder, and we can see it in as high as 75% of individuals with opioid use disorder. Also, similar to all people, having an episode of acute pain is quite frequent within human beings. So being able to address pain is important for people who have opioid use disorder as well. We're going to focus more on individuals who have chronic pain for the purposes of this mini video. So when we're thinking about individuals who have opioid use disorder and chronic pain, it's important that initially we want to make sure that we're treating the underlying opioid use disorder with medication treatments such as buprenorphine or methadone. Generally, we're using those medications over something like extended-release naltrexone, which would potentially be more harmful to their treatment of pain. It's important when we're treating someone who has opioid use disorder and pain that we're comprehensively evaluating the pain and providing a specific diagnosis. Remember that chronic pain itself is not a diagnosis, it's a symptom. So we want to be able to say, what is the source of pain that the person's having, if we're able to determine that. For patients who have chronic pain, we want to offer multimodal treatment options, including pharmacologic and non-pharmacologic treatments for pain. If patients are treated with buprenorphine and they're going in and they're having some sort of acute painful event, or they're having surgery, it's also important that we're not discontinuing buprenorphine because that could worsen their pain overall, and that could put them at risk to not stay on treatment, which we know is so important. Importantly, high potency full agonist opioids can be used in addition to buprenorphine when we are treating acute pain. And so in episodes where there are acute pain symptoms, or a patient is hospitalized for surgery, for instance, you can utilize high potency full agonist opioids in addition to buprenorphine. And finally, for both acute pain and chronic pain, if you have a patient who needs to be reinitiated or initiated on buprenorphine treatment, the low-dose buprenorphine initiation approach can be a helpful strategy so that they're not going through opioid withdrawal, which we know can be inherently painful and worsen pain over time. So we covered a lot of information in this mini video. In summary, when we're thinking about access to treatment for pregnant individuals, it's important that we are offering a medication treatment to them. We're not withholding treatment if they're not willing to engage in psychosocial treatments. We're continuing these medications throughout their pregnancy, as well as in the acute period of labor and delivery, or in the perioperative period if they're having a C-section. We talked about safety of breastfeeding and importance of eat, sleep, console. For adolescents, we talked about also lack of access to treatments for adolescents and how important it is to offer these treatments, even if patients are not willing or interested at this time to engage in psychosocial interventions. And finally, we talked about pain and how important it is for us to offer comprehensive pain evaluation in individuals who have pain and opioid use disorder. Buprenorphine and methadone can be effective medications for people who have concomitant pain and opioid use disorder, and that we should continue buprenorphine and methadone in periods of acute pain and treating with analgesic treatments on top of those medications if needed.